and we just have gone, since we went back into this room, we've gone to mute. So I think we should have to unmute the microphone.
Yes, indeed.
There we are.
So many thanks. It's a privilege to talk to you about the future of critical care medicine. Yes, indeed, I have been a couple of times in London, Ontario, and I still miss my good friend Bill Sibbald, who was head there a number of years ago, and we definitely miss him. So what about the future? Future directions, it's always difficult to predict the future, but I like this quote: the best way to predict the future is to create it. Or predicting the future is easy. It's trying to figure out what's going on now that's hard. So I will try to cover a number of aspects relevant to the future of our discipline. I will not speak too much about the age of our patients, but I need to start with it because, of course, the patients are at the center of our preoccupations. And also because some people say, oh, in the future, our patients will be so old. And it's true, over time, the mean age of patients in the ICU has increased substantially, today to about 65 years of age, but it will increase further in the future. But it doesn't mean that these patients will necessarily have all Alzheimer's disease or severe impairment. We will all be in a better shape for a longer period of time. And I think, but it's open for discussion, that our mortality rates will remain the same, but we will treat sicker and sicker patients. So we tend to say, oh, mortality rates have to go down, they have to go down. I'm not sure. I don't want to work in an ICU where the mortality rate would be only 5% or 3%. So we need to treat patients who are indeed more and more severely ill.
I just want to jump in for 1 second, Dr. Vincent. Sorry for interrupting. We had your slides up in the previous section. I'm not sure, they're not up now. I don't know if you wanted to share your screen again.
Ah, all right. So yeah, it was in the other room. Okay.
My apologies.
So let's, no. I didn't realize that we would lose the slides when we change rooms. But
there we are. Excellent.
Yeah, now you should see my slides, and it was about the age, to say that our patient populations will get older and older, but I hope the mortality rates will actually remain the same in the future. Now, there is a lot to say about the future of the hospital of tomorrow, but I will try not to expand on this as it would take too much time. But briefly, it's clear that the hospitals will be much smaller tomorrow than they are today, for a number of reasons, including the progress in medicine and the option to do more outside the hospitals. Now, how will the hospital system evolve? It's not very clear. It's possible that we will have small hospitals in diverse places in our countries, but it's also very likely that we will go to very big hospitals for problems which are not so urgent. If I need a good ophthalmologist, I may go from Brussels to Paris or from London to New York or elsewhere. So the big question in my mind is how much centralization of critical care services in the era of telemedicine, as of course, we will speak a lot about telemedicine. And with Dr. Osterman here, we listed some potential benefits of centralization, but also limitations. You may not want to be transferred far away from where you live. What about your relatives? What about the people you know in your environment and in the hospital? Decentralization would be possible thanks to telemedicine, but it may not be so good if the infrastructure is limited. So the discussion can go really both ways, and that's interesting. And I think it should be, the decision should be somewhat personalized. It's true that tomorrow, more than today, we will speak about trajectories between hospital, ICU, other parts of the hospital, home. And the limits between the hospital and the outside world will be blurred. They will not be as strict as they are today when we speak about, day of discharge from hospital. Because obviously, with telemedicine, we will be able to discharge patients earlier, but continue to provide some care at home. I was surprised just before the COVID crisis to see in some US hospitals that I visited that some patients could be discharged directly from the ICU to home. In Belgium, that's something that we could not hear about. And yet, when we look at this recent literature, the data show that it may not be a bad idea for some patients who are stable enough to go directly home, provided, of course, that there are good services to help to take care of these patients at home with telemedicine systems. So telemedicine has really a number of facets. It's not only for distant places where the infrastructures are very limited. It will be, of course, applied also in very sophisticated environments. Telemedicine will help in emergency medicine too, as the patients may arrive in the hospital with a better degree of accuracy with respect to the severity of the disease. How big will be the emergency department? It's another question. We could argue there will be bigger, we could argue there will be smaller. But if you are involved in some pediatric care, artificial intelligence will help to identify the severity of the problem in the distance. And so those who will arrive in the emergency department may already be in a way selected, and hopefully we will not need so big emergency rooms, as some patients will not go to the hospital when it is not necessary, and we will help them in the distance. But when they arrive, a number of variables will be collected from the hospital admission, and that will be done automatically. And then a triage nurse, of course, will orient to the appropriate specialist. Now, I think that as in our institution at Erasmus Hospital, I think that in the future we will have closer collaboration between the Department of Emergency Medicine and the Department of Intensive Care. In our institution, we have what we call a shock lab. That's just a word, but it's a small unit with 4 beds, which is staffed by both departments. So patients can come from outside the hospital through the emergency room or from inside the hospital. And the team can be informed in advance about the arrival of a critically ill patient and be prepared, in this case, to insert ECMO right away in case of cardiac arrest. So I wrote this piece with my friends Art Slutsky and Luciano Gattinoni about the ICU in 2050. And we said, you know, we will no longer be there, but our child may be there. So our child could tell us how life is in the ICU in 2050. And we learned that hospitals will be like a hotel, very nice hotel, as it can be the case already now, as here in Bangkok, for instance, or in other places where the scenery is absolutely beautiful. And of course, they can be garden, like here in the US, or here in Nouméa, in New Caledonia, where I went to work for a couple of months as a visiting professor. Look at the nice aspect of this hospital, so far away in a small island. And if you go to Utrecht, not far away from here in the Netherlands, you can find also a very nice department that looks like a hotel, again with a garden. I have been advisor to the Champalimaud Foundation, and that is in Lisbon, Portugal. And this is the internal garden of the hospital. And look at the hospital, it's a private hospital. Look how nice it is nearby the Taj River. And this is the ICU bed with the view over the garden, very nice room. And of course, a big screen. Simple cameras will just disappear. In the future, everything will be transferred by screen so that the staff can see us right away whenever they want to check anything on us. And we can also see the staff at the other side of the screen. So that will be a very important feature of the hospital of tomorrow. Now, the hospital will be much smaller than it is today, but the ICU will be bigger. So in Europe, we have about 5% of hospital beds, which are ICU beds, but clearly we will go towards much larger proportions of maybe 20 to 30% of the total number of beds in the hospital. So to make it short, it could be the hospital could be a large ICU with a few beds around it. I strongly believe that the future will be in multidisciplinary department of intensive care. And indeed, as a past president of the European Society, I defend it very, very strongly. In the US, I don't want to be critical, but we all know that they have many ICU beds in many separate ICU, the respiratory ICU, the surgical, the trauma, etc. Whereas in many places of the world, we have rather general ICUs. Of course, burns can go to a separate area, children can go in a separate area, the coronary care unit could be separate. But there is no reason to separate medical and surgical patients. Surgical patients are medical patients with a scar. They develop the same problems. We speak about sepsis, respiratory failure, shock, renal failure, delirium, electrolyte disorders, nutrition, etc. Why do you want to separate medical and surgical patients? And in the US, they like to speak about the neuro ICU. This patient must go to the neuro ICU. But if there is no room in the neuro ICU, the neuro patient will go in the nearby ICU, in the cardiothoracic ICU, to give an example. And then, oh my gosh, this neurological patient here, that patient will be less well treated than in the neuro ICU. Moreover, patient arriving with coma may develop respiratory failure, and the patient with respiratory failure may develop coma during the stay in the ICU. And again, they develop the same kind of problems and complications. Why do you want to separate a neuro patient from another patient? And we have had these discussions with my good friends in the US about this, I don't think we need a subspecialty in neuro-intensive care. And hopefully in most parts of the world, we speak about a place where we admit patients who need special attention and who are critically ill. So in our institution too, we abandon this and we have now units 1, 2, 3, 4, 5, and we admit according to bed availability. I am not even so sure that we need high dependency units or step down or step up units, you name it the way you like. We prefer in Brussels having large department of intensive care where all patients are mixed actually, those who are more severely ill and those who are less severely ill. It's easier in terms of management. Now, what about the relation with the floor in the future? That's very important. And I like the North American approach of critical care medicine versus intensive care unit. In Europe, as we know, we speak about intensive care medicine. We don't speak about critical care medicine that much. But the concept is good. Critical care medicine could be broader than management in the ICU. And clearly, we need to be available to admit patients at the right time in the ICU. Otherwise, it's too late. The patient may stay for several days after cardiac arrest in the ICU and die with post-anoxic brain damage, whereas an earlier admission could shorten the ICU stay and allow the patient to go back to the ward in a relatively good condition. So that will be an important task for the years to come. We all know we want to avoid code blues. We want to avoid cardiac arrest. We want to have rapid response systems. I think that's the best abbreviation, RRS. And for this, we need to have a better monitoring on the regular floor. I'm not sure we need a prospective randomized control trials to show that it works. It is just so logical. We had a roundtable conference on this in Brussels just before COVID. And by the way, yeah, we propose to call these systems the rapid response systems, MET teams. It may not be only medical doctors and RRT, rapid response teams. That's a very bad abbreviation because RRT for us means renal replacement therapy. So let's call it RRS. So in the future, we will certainly have better systems technologically. We will have reliable systems and the data analysis will be increasingly accurate so that we will accept these systems, hopefully. And when I say we, it is the team and the patients. We know that the EKG can be monitored very easily today. Likewise, the respiratory system, there could be acoustic monitoring, there could be plethysmography to record the respiratory rate. Respiratory rate is a very important variable, as we know. There are masks that have inbuilt systems that allow us better monitoring of the respiratory system. Pulse oximetry, as we know, is good, of course, but it has limitations. Disconnections, artifacts, and the information is only partial. We will have better closed loop systems in the future to adjust the FiO2 of patients on the floor. But we know that SpO2 is not everything, and we will monitor expired CO2 and other respiratory variables in the future. Now, alarm fatigue is an important thing, so we need to combine various systems to record these variables and minimize the risks of false alarms. In the future, we may even monitor expired gases, not only in mechanically ventilated patients. I am on the floor here. And clearly, the monitoring of ventilation will actually improve in the future. So, indeed, An integrated signal could be generated so that if there is a fall in SpO2 and an increase in heart rate, it makes more sense than a fall in SpO2 alone that could correspond to an artifact. This is one of the hospitals I visited recently, the Baptist Health South Florida, where they already have an approaching system to evaluate the patient at risk on the regular floor. And if indeed the alarm is triggered, we know we have to go there right away. There are some other systems that could monitor the very early stages of hypovolemia, as I've seen in this military hospital in San Antonio. It's very interesting. But these monitoring systems will be very comfortable for the patient with, very small sensors, even on rings. And that's how we wrote this piece, News for Hemodynamic Monitoring, Non-Invasive, Ergonomic, Wireless and Wearable Sensors, Smart Software, and Algorithms. So once again, rapid response systems will be much more elaborate in the future. We will no longer use this very nice modified early warning systems, which are very popular in the UK. I think they can be useful today, but they will be much more sophisticated in the future. Even at home, we will have better monitoring systems. And that's what we learned with COVID-19 too. Have you seen these very small wireless sensors that could gently sit on the throat to monitor cough, fever, and respiratory activity? And all of this, of course, will be helped with artificial intelligence for diagnosis, and also without all these wires, it will be wireless systems, and for, again, very simple systems that will be used, and more importantly, for prediction, to see which patient deteriorates. With big data, artificial intelligence, we can quite easily identify the patient who is likely to deteriorate. And again, that will be a way to act earlier than what we do today. And finally, of course, artificial intelligence will help us with therapy, but I have no time to dwell on that. There will be automated systems. You may remember this excellent paper by Komorowski showing that artificial intelligence systems could do actually probably better than ICU doctors now to decide whether we should give more fluids or more vasopressors. And we could have automated systems that could adjust the doses of vasopressor agent, including in anesthesia, as my protege, Dr. Josten, showed in several very nice papers recently. Now, of course, we need to feed the system. I would like to emphasize that artificial intelligence will not work by itself. So we need to give the newest information to the system. If we have to do something about COVID-19, we need to tell the system where baricitinib may be placed, or now molnupiravir, which is the hot question of the day in the management of COVID-19. So what I would like to stress is that the role of the doctors is evolving. We will not be replaced by these systems. We'll have to control them and orient them. So let's move on. We could actually raise the question, if we have these better monitoring systems, could we keep what we would call the ICU patient, or the more critically ill patient, on the regular floor and just transform some regular beds in ICU beds? And this is not necessarily stupid. And in some hospitals, as we know, there are some of these beds on the general ward. We must be careful not to lose what we have accomplished. We have gained a lot by grouping critically ill patients in a single area. So I do believe that most patients will still go to the ICU, even though we may have automated defibrillation systems. So let's speak about organ support. We use less and less non-invasive ventilation. We like to use helmets in Europe in some of our patients, and you can see that over the years, we use less and less invasive mechanical ventilation. We all know that, but the data illustrate this. Now, to return to the Champalimaud Foundation, we hardly see the respirator in the room. If the patient has to be intubated, we could call for the robot. We don't need a doctor for this. Don't call for the anesthesiologist, just bring the robot in the room. But the important thing is, in the future, can't we use more extracorporeal systems and try to avoid endotracheal intubation for many patients? The ECMO systems have been simplified from several years ago. Now it's so easy. In the ICU, it's just routine to insert ECMO in our department. That's no problem at all. And the instruments are getting smaller and smaller, so that in the future, in many cases, we could simply use these extracorporeal systems instead of the respirator. And the patient may remain on the floor with this system purifying the blood from CO2 in particular and bringing some oxygen. We could combine it with renal support. This is my friend Claudio Ronco inserting a renal support system in a neonate. You can hardly see the neonate, and the machine is much bigger than the neonate. But we are going towards wearable hemodialysis systems, right? So the patients will have also much simplified renal replacement systems. And perhaps we will eliminate toxins at the same time. The mediators in excess on the toxins may be bacteria. There are now some systems that can eliminate bacteria from the blood. So extracorporeal organ systems will, I think, make much progress and be combined with liver support and with cardiac assist devices. So that's how we proposed a couple of years ago the ECOS system, the extracorporeal organ support systems, combining support systems of the various organs. It's part of the future. Now, with all of this in mind, shall we still use a stethoscope? I think hardly so. Hardly so. It will remain our symbol. We like to have the stethoscope around our neck. Yes, of course. But, you know, we hardly listen to the chest. We ask for a chest x-ray. We hardly listen to the cardiac murmurs. Do an echo. It's much simpler and it brings more information. So, yeah, we may keep it around our necks and use it in very unusual cases, but clearly the stethoscope will no longer have an important place in the future. Imaging will change a lot. With smaller instruments brought to the bedside, CT scanners that we will have available without having to move the patient. And indeed, the images will be collected on our smartphones anywhere, from the ambulance to our smartphones or from any other place. And we will see the lungs so much better than we do today. So it's true also for the lungs in respiratory failure. And we can do many things in the distance indeed. Surgery can already, of course, be performed several meters away, but in the future it will be some kilometers away. So the implications are clear. We will be able to call a surgeon in the distance or a cardiologist in the distance for an acute MI that I have here. I don't need to transfer the patient to another institution. I can just ask the invasive cardiologist to do the procedure from the distance. So the specialist will have an evolving role. What about the infectious disease specialist? Will we still need them? What do? They integrate the information we provide, and then they propose an antibiotic or an antibiotic combination at given doses, and they think about the escalation. But all of this could be done automatically as proposed already in the last century. So, for infectious disease specialists, the future may not be so bright exactly as for the radiologists, as the interpretation of the images will be done automatically. So there will be less doctors on site. With telemedicine, the patients will be happy to see their doctor even when the doctor is at a meeting in another country. Remote examination will be possible, and a robot could help to collect this information. If you still like to use a stethoscope, you can do it via a robot. So telemedicine can find a number of applications, actually, even in the ICU. On weekends, you could call your colleague who know the neurological problems better than you do, or the severe ARDS better than you do, or the ECMO systems better than you do. And instead of having someone on the phone, obviously, having a better communication system will certainly be very welcome. Now, some time ago, as many Europeans, I had my hesitations about these multicentric ICU supervisions, but I became increasingly convinced. And indeed, when we heard in places like Atlanta that in view of the lack of ICU doctors, they sent their doctors to Australia to get doctors there who could supervise the ICUs during the night in North America, but during the day in Australia. That's not a bad idea, to send younger doctors for a couple of months in Australia to work there during the day and cover for the nights in North America. It's not a bad idea, because the doctors will be quite happy to have this experience, and we could have the benefit of having well-rested and well-alert doctors on call. Protocolized care, big issue. Of course, we all use some protocols, at least for heparin therapy, for glucose control, but in some centers, they love protocolized care. And this type of study that I have always called stupid has really not helped. Why do you want to take up? I told them from the beginning when they started the study, and all these guys are good friends of mine. I think they're mostly male. That's the reason why I'm saying guys. But they did a study comparing one blood pressure level to another blood pressure level in a mixture of septic patients. But I told them, you will never find the difference, my good friends. And of course, there was no difference in outcome, because some patients may need a higher blood pressure, but some others may be hurted by a higher blood pressure than the optimal one. And in the other group, just the opposite. There are some patients who may suffer and some patients who may actually improve. I reviewed this paper. I told the JAMA editors, I don't like the study, but the study was conducted according to the protocol. I know you will like to publish it because it's a large prospective randomized controlled trial. And of course they published it, but it doesn't help. Of course, sometimes we can allow the patient to stay with a lower blood pressure than someone else. I love this old picture of my friend John Marini making rounds with us, and I like the hand on the mouth of the young doctor listening very carefully to the expert. We still need to think at the bedside. And that's a big problem in the US, where they lack ICU doctors. And so there is not enough ICU staff. So they need protocolized care. But this decreases the interest for the specialty. There is no pathophysiology. There is no thinking. There is no intelligent care. And of course, I'm a bit schematic here. I don't want to criticize the US system. I'm saying that excessive protocolized care will actually encourage people to stay away from the ICU. Whereas interpreting the cardiac output, the SVO2, the change in lactate levels, etc., how to interpret the lung compliance, the thoracopulmonary compliance, etc. That makes our specialty so nice. So this paper just came out. Actually, it is in the November issue of Critical Care Medicine. But it shows that we have more and more prospective randomized control trials. That's very good. But the problem is that many of these trials target mortality in heterogeneous patient populations with negative results, negative results, negative results, negative results. Or they just don't bring any information. Have you seen this study from Brazil? Good friends of mine, once again. But they gave 1.5 liters of either saline or Ringer's lactate. And you know what they looked at? They looked at mortality. Do you really think that 1.5 liters of saline solution will change the mortality? Look at the chloride levels. If there is a change in mortality, it's due to hyperchloremia. But when you give 1.5 liters of saline, there is no difference in chloride levels, as you can see here in the right diagram. So that does not bring any information. And now we have seen the surviving sepsis campaign guidelines. And so a number of us reacted to it and said, you know, the surviving sepsis campaign guidelines consider that all patients are identical. That's wrong. Let's go into personalized medicine. Patient management should be individualized. In the future, our bed systems will allow us to evaluate the need for fluids by changing the position of the patient and raising the legs. All of this will be done automatically, but personalized. We need to move up from poorly characterized patient populations to personalized medicine and one day precision medicine. And we will also have more information about pharmacology and pharmacogenetics. So when we look at, you know, hydrocortisone in septic shock, we know it works in severe cases. It doesn't work in Australia when 1/2 of the patients were in shock and the other half was not in shock. But this is not enough. So with Dr. Halan and others, we are looking at biomarkers that could show which patient could respond to corticosteroid administration. With new sepsis therapies, thrombomodulin, coagulopathy is the signal. And that's how we could show in this recent study that if you look at the right side in patients who had really the baseline coagulopathy, when we start to give the drug, there was some signal of a reduction in mortality, not enough to have a product available, but enough to be encouraged to do another trial. We are in the era of phenotyping, of trying to have the right biomarker for the right therapy. Remember the famous study 5 years ago in ARDS showing that they can be different profiles, and some may benefit from fluids more than others. Unfortunately, initially, they mixed up the two groups so that the data didn't make so much sense, but they corrected it. And of course, it's the more inflammatory phenotype which benefits from fluid therapy. Simvastatin, that was the first study in all ARDS, no difference in outcome. But, and I reviewed this paper, which is really very interesting, when they looked at phenotyping, clearly the more inflammatory state benefited from the anti-inflammatory effect of the statin. That makes sense. So ARDS is not ARDS is not ARDS. We need to individualize our therapies. And this paper just came out 3 days ago. That's in COVID-19, showing how we could individualize the ARDS associated with this disease. And this came out today, this morning. Very interesting statement from the American Thoracic Society, how to develop precision medicine with good advices, good recommendations. There are 5 or 6 recommendations, but clearly we are going out of these large trials asking a pragmatic question in a very heterogeneous patient population. In nutrition, the same thing. Look at what we have learned. It's always on critically ill patients, critically ill patients, critically ill patients. We need to be more specific. Okay, let's go into more humane aspects to finish. In the future, we will be increasingly concerned about the outcome of our patients, not only in terms of being alive or dead, but in terms of physical function. I think we will use less and less sedation. Today, many people say, oh, no, we try to avoid sedation. But when you go in the ICU, when you go at the bedside, there are still many patients who are sedated when they don't need sedation. So, they can keep a prolonged weakness associated with that. That's how my colleagues and I proposed the ECASH concept, early comfort, of course, preventing pain, but with no or minimal sedation and always humanized care. So patients can be mechanically ventilated and read a travel brochure to go to Canada in a few months. That's the Calm Comfort Cooperation. And this is a patient in our department who took the book by herself. She was English speaking. She wrote, she read an English book. You may say, well, did she need a mechanical ventilation? Sadly enough, she died 2 days later from severe heart failure, but we could not wean her from mechanical ventilation. Patients can watch TV when they are mechanically ventilated, etc. And moreover, the patients can actually go out, and we do encourage our patients to go out. We encourage patients to do exercise, but I'm sure you do too. But we have to do more to mobilize. We like, with our physiotherapists, hopefully we have enough of those, we like to invite patients to move and push their respirator themselves. Go outside when the Belgian weather allows it. But this is a view from Barcelona, where they also bring patients. I love this picture. I think that's really a picture of the future. And indeed, Zora maybe will help to do the physiotherapy. So it's not only a matter of manpower. The patients will be able to go to some area of the hospital. We will know where they are because we will be able to follow them up and know where they are, but they will go and do their exercise. This is right now in a Dutch center. They have their own pool, their own small pool, and mechanically ventilated patients go and can try to swim a little bit when they are mechanically ventilated. I love it. I would love to have such a bath, a bathtub, big bathtub in our intensive care unit. But we have had some experiences with these systems reproducing walk at the bedside, so that mechanically ventilated patients and other patients who cannot walk far away can walk just beside their bed. So I think that all of this will be implemented more in the future, including balloons, which are very cheap, to invite the patient to play football. Shall we still need doctors? That's my last question. And the role of the doctor will evolve, but clearly we will still be needed. I think we will still need to have these rounds at the bedside, old stories, as it has been the case for so many years. And this is important for a number of reasons that I have no time to describe. So again, I don't want to be critical, but there is a risk. With modern technologies, there is a risk that we all look at our computers, as I am doing now, instead of spending more time at the bedside. These are good friends of mine, and they share my concern. Absolutely. We need to be careful not to look at the screens only, but look at the patients. And relatives and friends will be more involved in the future than they are now. But in Europe in particular, the relatives were kept away a bit too much in our ICUs, and we need them also to distract the patient. And again, the robots will talk more to the patients in the future. This is a view from our ICU. The first time we brought a dog to help this young lady to keep her spirits, and she was so happy to see her small dog. But now, as we know, this has become more widely applied, and here in the UK, there was even a horse coming in the ICU to visit the patient. You can see that they took all their precautions to keep hygienic measures. So the place of the relatives will be increasingly important in many parts of the world. And actually, telemedicine will help the patient to also be more in touch with relatives and with the caring team. Ethical approaches will be, of course, very openly discussed. I proposed the ICU test many years ago. If we hesitate to admit the patient in the ICU or not, I propose that we admit these patients in the ICU and we stop if it doesn't work. Are we always reasonable when we speak about sepsis, which is one of my fields of interest? Some people say there are too many people who die from sepsis. How many again? You know, I always say I would like to die from sepsis, but not now. No, in 20 years from now, in 20 years from now. But it's not a bad death, you know, to fall asleep. And look at this excellent editorial. I love to present it, about this doctor who said, oh, I brought my mother, and they immediately wanted to insert lines, give fluids, vasoactivations, but my mother had terminal Alzheimer's disease. She was in a nursing home, hopeless. So we need to take this into account as well and discuss it with the relatives and orient them. And finally, the patient experiences will be, as we know, collected more and more objectively. And this is important as we will be evaluated on our practices. So to summarize, as I'm reaching the end, the future trends: prevention, prediction, phenotypes. Patients will decide more than they do today. The hospital limits will be much less well defined, and we will be more concerned than ever about outcomes, not only in terms of survival or death, but in terms of functionality and quality of life. So I never think of the future, comes soon enough. I agree, but we need to prepare the future. And we can be optimistic. The future is bright. New technologies will contribute to better care. There is no substitute for human care factors. The patient will remain at the center of our preoccupations. So we can be proud of what we have accomplished and what we accomplish every single day. We will still need people in the future. They will not be replaced by robots and machines. We will work in harmony with modern technologies. Thank you.
Thank you very much. That was an incredible sort of whirlwind tour of the future of critical care medicine. So that was great. I would like to open up the floor to any of the participants. If you could just maybe text in first to the chat if you have it, or just unmute yourself. And if you want to ask Dr. Vincent a question. Yeah, Dr. Hedera, go ahead.
So thank you again, Professor Vincent. It's a real pleasure to always listen to you. I was in Brussels last month, and it was very nice to see everybody together again. If not everybody, at least enough people. I guess my question to you is around the research agenda that critical care has. And I think a lot of us are dismayed at this what I think most of us would say is an undiscerning approach to examining the important questions in critical care. Large heterogeneous populations, poorly thought out methods in terms of the separation of the groups. And the question is, how do we change that? We're spending probably hundreds of millions of dollars a year on these studies to find no difference, but also to not really advance the questions that are really important.
Yeah, that's a great question. And of course, it's a very tough one because it would take another hour to discuss it. But I think that the overall concepts are one, that we should not forget physiology and basic concepts. And I'm afraid that everywhere in the world, people like recipes more than physiological approaches. Now, at least from the outside, because when they come in the ICU and when we start to discuss the various elements, why do you think the SVO2 is low? Look at the hemoglobin level. What about the cardiac output response to that? Or what about increasing the PEEP level? And let's look at the lung mechanics here. And what do you think? What is the optimal PEEP for this particular patient, etc.? That's or for neurosurgical patients. What about raising blood pressure and look at the ICP level? People love it because good doctors, they must love physiology. So that's one answer. The second answer is indeed the therapies based on particular mediators. You know, right now there is a study. I mentioned our study on thrombomodulin in patients having an established coagulopathy. We could mention the story of adrenomedulin levels to guide anti-adrenomedulin therapies. I spoke about corticosteroids and how there is a very big European budget to look at it. It's a huge amount of money. It's millions of euros devoted to that. A couple of millions of euros devoted to that particular question. Even if we take a much more specific aspect, which is COVID. 1 hour ago, I was called for a difficult patient and they asked me, what do you recommend for treatment? And I said, should we give tocilizumab? But I said, how bad is the inflammatory response? Because if you tell me that the inflammatory response is not really very high, why would you give an anti-IL-6? And so we need to have, for every single intervention, we need to have the appropriate information. Some people may prefer to avoid corticosteroids in a patient with decompensated diabetes, etc., etc. So individualizing therapies. In terms of, so that's already the basis for trials. Returning to the physiology, the people tell me never give a transfusion unless the hemoglobin level is below 70. See, where does it come from? Oh, there is no difference in mortality, whether you give more blood or less blood. based on hemoglobin concentrations, but I never give blood only on the basis of a hemoglobin concentration. Of course, I look at the hemoglobin concentration, and I would not give blood to a patient having a normal hemoglobin concentration unless he is already bleeding to death under my eyes. But I take care of the other elements. What about coronary artery disease? What about altered tissue perfusion? What about SVO2? But this is not in the clinical trials. It's not there. People were randomized according to a hemoglobin level, and it did not change their mortality. No. So we don't have the proper answer for blood transfusions. Or we could actually have some answers that we and others generated on large patient populations, looking at a number of variables and separating patients who received blood and patients who did not receive blood. And when the situation is indeed severe, we realize that blood transfusions could be beneficial. So, but the advocates of prospective randomized controlled trials will say, no, we cannot have a substitute for it. So I'm asking them, what kind of protocols could you have for such an RCT? And that's not really easy to write a protocol taking into account these variables. So the situation is extremely complex, and I will not find easy answers right now.
Any other questions from the audience? You want to text in? I think you sort of already touched on this, Dr. Vincent, but with respect to phenotyping, I'm curious how you see the phenotyping being done in the future. Because I sort of, COVID is a good example of Dr. Gattinoni proposed the H&L phenotypes, and everybody sort of said, oh, there's not enough evidence for that. There's no way that we can differentiate therapies or treatment based on that phenotyping. So is it a molecular phenotyping? Is it a response to therapy? Is it an inflammatory phenotype that's biochemical, like you suggest? Is it Gestalt? How do you see that phenotyping coming down?
Yeah, very, very good question. And I think it's a combination of all. You know, it's our problem that we try to find simple answers to very complex questions. And we would like to find the variable. What is the optimal blood pressure in patient with septic shock? That's too simple. It's too simple. You cannot look only at blood pressure. You know, some people look at heart rate. They say, oh, fast heart rate. You need to give beta blocking agents if there is excessive tachycardia. Excessive tachycardia, okay, but what do you call excessive tachycardia? Can you tell me what your algorithm is before you would perhaps give beta blocking agents? Because if you don't do that, sorry, I will be very crude, but you may kill a patient by giving a beta blocking agent when there is tachycardia, but no high cardiac output with good tissue perfusion. So again, we need to use different variables. Some people ask the question, can lactate levels alone guide resuscitation? I'm a big advocate of lactate levels, but my answer to the question is no. You cannot use the lactate levels alone to decide how to treat a patient and for how long to treat a patient. No, I'm sorry. Lactate levels have their limitations like any other variable. As you say, Luciano Gattinoni in COVID proposed to have a type 1 and type 2 ARDS. Does it really help? I think it's a little bit too simple, but ARDS, after all, is not a disease. And so we have no treatment for ARDS. Even corticosteroids in severe cases, it could be debated. What do you call a severe case? And we all have our hesitations. We look at the inflammatory syndrome before we possibly give corticosteroids to these patients. But we have, tried to treat these patients with anti-ARDS therapies or lung protective therapies for so long with zero result. You will say, oh, the large tidal volume. I agree, but that's harm we could show, and it's very important. It's very important. We could show that large tidal volumes could be harmful not only in ARDS, but in any mechanically ventilated patient. It's dangerous for the lungs. Okay, so that's what we have shown. But in terms of positive effects, positive pharmacological agents in particular, the last one I worked on was interferon beta, and it didn't work. We published it in the JAMA just before COVID, but it didn't work. So ARDS is so heterogeneous that Dr. Slutsky and I wrote a piece in Intensive Care Medicine, which is entitled, "We have never seen an ARDS patient." We have seen many patients with lung sepsis, with extrapulmonary sepsis, with aspiration, et cetera, but ARDS, and now, as you could see with the COVID, it's coming back. People say, do we need these syndromes? I like to use the syndromes because when I make rounds in your department and you tell me, oh, here we will present you a case of ARDS, okay, I know what we will speak about, but it doesn't tell me which treatment I should apply. I will wait until you tell us more about it. So I think the future is really personalized medicine. I really believe that's the future, and I'm happy to see that there is now a movement going in that direction.
That's very helpful. I'm going to pass it off to Dr. Leligowitz, but just like it's a comment that it's interesting, two sort of figures. Dr. Cohen said the same thing, that ARDS is not a disease, yet we seem to spend an inordinate amount of mental energy and research on it. So if all of the sort of pivotal people in the field don't think it's a disease, it's an interesting construct that still has staying power. So thank you for saying that, but I'll pass off to Dr. Leligowitz.
Thanks, Paul. Thank you so much for the very enlightening and engaging presentation, Professor Vincent. I just have a question and more of a philosophical approach that you might take. Given the fact that you've been involved in so many sentinel trials, how do you think their results are going to change as we start to, or the interpretation of those results is going to change as we start to redefine what is sepsis, what is ARDS, and as we start to incorporate these phenotypes and biomarkers into potentially future trials? Do you think we should redesign those trials again, reevaluate them? You know, where do you think this is going to lead us in the future?
No, I think we need to revisit our strategies. That's what I think we need to do. You know, I have been in the recent consensus on the ARDS, and we changed the criteria. So what? We add a little bit of PEEP in the criteria. So what? How do you think it will really influence our chances to find an effective therapy of ARDS, which is not a disease? So for sepsis, I have been involved in all these consensus meetings, except the one on SIRS, because I would never have accepted that. That was a North American stuff. But all the others, I have been involved in the consensus groups, and I have always claimed that sepsis was defined for the first time by Hippocrates. Sepsis, ask any Greek person, I don't know if there is a Greek person in the audience today, but sepsein in Greek means putrefaction. So it's a situation which was described in all times with organ dysfunction, obviously. So how could you speak about sepsis without speaking about organ dysfunction? What is the last patient you treated and that you called a septic patient? You said a septic patient, as John Marshall would say, a septic patient, because there is clearly either some hypotension or some obtundation, decreased urine output, whatever. There is an organ dysfunction associated with it. So, the sepsis must include some degree of organ dysfunction, and that's what I fought for in so-called sepsis 3 definitions. But I told my colleagues, we should not speak about sepsis 1 and 2 and 3 and 4. Sepsis has always been sepsis. Now, if you want to speak about criteria, because we confuse definition and criteria. We speak about the new sepsis definitions. No. Sepsis has always been like that. It will never change. Now, if you speak about the criteria for a publication, you could say, okay, it's an increase in SOFA score by 2 points. Okay, you can define the criteria you like, and this may change a little bit. Okay, it's up to you. But the definition will never change. Exactly as for the myocardial infarction, it has always been a clot in a coronary artery. Now, in former times, we didn't know the troponin, and even in many decades ago, we did not have the EKG. But okay, so we could have EKG criteria, we could have troponin criteria. These are criteria, but they don't change the definition of the myocardial infarction. So I don't think we should, right now, there are some people who would like to revisit the criteria for ARDS. I don't think it will be very, very helpful. And I don't think we should revisit the studies we have done on these bases. You know, look at the studies on pneumonia. You know, the criteria may be different from one study to the other. Does it really matter so much when you read a paper on pneumonia? You say, okay, they say we treated 100 patients with pneumonia. Okay, you know that the criteria will be more or less standard. Do you really need to have very strict criteria? I don't like this Akin and Rifle and KDIGO criteria. No, renal dysfunction is part of multiple organ failure. So yes, we need to look at creatinine and urine output, but exactly as we need to look at PF ratio for the lungs and the need for vasoactivations for the cardiovascular system, etc. So we should not take renal dysfunction. I still speak about renal dysfunction. Many people say AKI. That's terrible, terrible letters, AKI. Renal dysfunction or renal failure, that can indeed occur alone, but it's rare. Usually it's not in isolation. Usually it's combined with some other forms of organ dysfunction. So I'm not sure I addressed your question correctly, except to say that I don't think we need to repeat some of our trials. Once again, I think we need to look at better defined patient populations, but we could use the criteria which are appropriate for the patient population we study. I was so excited to read in Science last year an excellent paper in Science showing that in COVID-19, you can find endotoxin in the blood, and the endotoxin levels are directly proportional to the cytokine levels in these patients. Endotoxin in a viral disease? Yeah, these are the data. These are the facts. So they come from the gut. So you can find endotoxin in the blood of patients with COVID-19. So COVID-19 is not just a viral disease, it's viral sepsis with a number of elements that could play a role. And who knows, perhaps in some of these patients, anti-endotoxin strategies, maybe I'm not, just a hypothesis, maybe some anti-endotoxin strategies could be beneficial. Who knows?
I think that's a great explanation and probably a good place to finish. We're coming up on 75 minutes here. So with no other questions in the pane, I'd just like to sign off and thank you very deeply, Dr. Vincent. That was a treat for our faculty and our learners to have opportunity to hear from somebody of your common sense as well as your stature. And it's greatly appreciated you taking the time to join us today from Brussels. And hopefully you've got a peaceful, restful winter coming up for you. Okay, have a great day, everybody. Thank you.